this presentation. So now it is my great honor to introduce Dr. Andrew Krystal. He is the Ray and Dagmar Dolby Distinguished Professor in the Departments of Psychiatry and Neurology at UCSF. He's a leading figure in the field of interventional psychiatry, serving as Vice Chair for Research in the Department of Psychiatry and directing both the Dolby Family Center for Mood Disorders and the UCSF Interventional Psychiatry Program. As you'll hear, he's a pioneer in applying computational imaging and modeling to develop markers for depression and sleep disorders and personalizing their treatments. He has over 50 trials under his leadership, and his work is transforming the field of precision psychiatric treatment. I've been deeply inspired by his work. Please join me in welcoming him to the stage to give his presentation. Thank you.
Thanks very much. I'm honored to speak at this great symposium. Thanks for inviting me, Leanne. These are my disclosures. So we are hopefully all aware that we don't do as good a job treating depression as we should be doing or we would like to do. And this is surprising in some ways to me because we have like more than 50 FDA-approved treatments for depression. And you would think that would allow us to do really good treatment of depression. I'm going to focus on two things that I think are important reasons why we don't do better. And one of them is the degree to which we are personalizing our therapy or able to personalize our therapy. So we have all these treatments, but we have no idea who to give which to. It's basically what you're used to, a coin flip, trying to match side effects. And so we're not doing any better than the population responses to the single medications. And then the other is lack of doing new treatment development in a framework that's related to depression mechanisms, circuit dysfunction in people. So that what we're getting is a whole bunch of different treatments that were either serendipity developed or relate to increasing norepinephrine and serotonin, or like very, very small tweaks on things we've already had. To make an important, meaningful change, it seems necessary to be targeting to underlying dysfunction pathophysiology if we can. I'm going to start with talking about personalization. And, it's obvious from symptoms that depression is extremely heterogeneous. We have this 5 of 9 diagnosis. It's extremely varied, the presentations you see in people. And then we have the underlying alterations in circuitry that are different. And I'm getting a chance to show this great paper that recently came out. I've been a huge admirer of Leanne and her group's work for many years, and this was another great contribution. But you see different circuits being associated with different symptoms. Okay, these are they subgroups? There's a sense in which they do represent subgroups, and I think thinking about that when thinking about treatments is really important. I'm going to shift gears and move from the issue of I'm not going to shift gears, sorry. This is another piece of evidence about the issue of personalization. So we have got a large number of studies that have been done with deep brain stimulation. Electrodes are planted in the brain and direct electrical stimulation of tissue occurs. And there have been some pivotal trials that have failed. There's been a bunch of different targets in different areas that you see here on the slide. And in each one of them, a subset of the people do well. And if you take them all together and you do a meta-analysis, you find that there's actually a statistically significant therapeutic effect across all of these. So different people are responding to stimulation in different places in the brain. Doesn't seem to be one spot or some kind of single circuit target. And so it's not a failing of the method because lots of people do get better. It's heterogeneity is what it looks like. And two big categories of personalization, I think. The one is subgroups related to the kind of work that Leanne is doing. You have types, subgroups of people. And then the other is working at the individual level. So I'm going to start out with subgroup related work. And, I'm talked about the idea that I'm planning to talk about circuit targeting development of treatments and personalization. The two interlap in some ways. So this is what I'm going to talk about is how we need to move towards personalized circuit targeted therapy. And we have a big challenge in the field about having limited new treatments. And I think we're all very familiar with this. And our strategies for developing treatments work really well if you want to develop an SSRI, but we got more of those than we need probably. And we need to look at this in a different way. And the failure rates of the treatment development processes have gotten so great and the costs so extreme that pharmaceutical companies have pulled out. This happened about 10 years ago, but it was so extreme that people haven't returned. Pfizer, the largest pharmaceutical company in the world, does not do central nervous system drug development to this day. Neither does GSK. And these costs have really altered the field. So what can be done about it? Well, one strategy is to try to figure out where the problem is and attack it. And phase 2 studies, that is, after the first in human studies, you do the first in the clinical population, that's phase 2, and then you go to these big randomized trials of the clinical population, and then you submit your application to the FDA. So phase 2 trials are the gate to the most expensive part of the process, those huge pivotal trials. And they keep telling us to proceed when the efforts then fail because the phase 3 trials are negative. So just a few examples here. I'll just go through one. $1.24 billion investment made in a nicotinic channel modulator for depression. It was a lot of excitement, had strongly positive results in the phase 2 study, which is what led to the investment and the excitement. In 4 out of 4 phase 3 studies, it failed to beat placebo. I mean, there's many other examples. I'm not going to go on. But so what's the problem with the phase 2 studies? Well, it's not my idea. A number of people have proposed that one challenge is that we're basically doing underpowered studies. We're taking clinical endpoints that when we get to phase 3, we know we need 1,000 people, and we're trying to do 100-person studies and get something useful out of it. And over, we're not. And the problem that has been proposed is that we're using clinical endpoints. Those clinical endpoints require the 1,000 patients to show effects, and they're one element of a challenge. Another one is that, and this is related to the circuit targeting and the mechanism story, that people basically do trials and they ask the question, does this drug beat placebo? Okay, there's no scientific framework for that. And a drug could beat placebo for many, many, many different reasons other than that the drug is actually therapeutic. And so it leaves you open to all kinds of non-specific effects and decreases the likelihood of replication. So strategies out there have been discussed. One of them that I'm going to talk about is what's called fast fail. And this is meant, fast fail is, the fast fail part of it gets one's eye. And the idea of fast fail is most of these efforts fail, let's fail them fast and accurately and save money. But there's another part of it, and that is that drug development happens in the framework of a scientific hypothesis grounded in the brain. And so the idea is that you identify a target that you think has some effect on the brain, and that mediates the therapeutic effect. And then what you do is before you proceed to studies with clinical endpoints, you do studies that test that hypothesis. If that hypothesis is not right, your foundation is garbage. Why would you proceed? So the idea is to do a proof of mechanism study, testing, let's say I'm going to tell you about a study in a minute, whether engaging the Kappa opiate receptor with an antagonist that is blocking it very, very strongly leads to the effect on the brain that you think is going to lead to a clinical effect. And you do that first before you go into the clinical endpoint studies, because that decreases the likelihood that positive effects in the clinical study are due to bias and related kinds of things. So, and the other thought is you can probably get away with smaller studies because the biology is closer to the target engagement, which is on the biological level, circuitry, than if you move to the domain of clinical outcomes and people's experiences and responses. So you can maybe get away with those 100 patient studies. That's the idea. And so, as I mentioned, doing that which should decrease the likelihood that if you have a positive study, that you have a non-specific bias effect. But the other is, if you get to phase 3 and you do a clinical trial and you fail, it would be, you've robustly engaged the target, because in this strategy, you have to choose a drug at a dose or any kind of treatment in a way that robustly engages your target. Because this is, otherwise the whole thing doesn't make sense. Underdosing can kill an effort also. But once you get into phase 3 and you have a negative study, it's interpretable. You know what it means. It means you were wrong. Your hypothesis that engaging the brain in that way leads to the therapeutic effect you thought it was going to lead to is not right. You need to go back to the drawing board. Don't do another study with a higher dose, which is what pharmaceutical companies have been doing for 1 million years. So I had the opportunity to do a study in this framework. I want to walk you through it just so you understand what it looks like. And it was based on a basic science literature, which is very robust, related to anhedonia. And this was related to the Kappa opiate receptor system. It's a type of opiate. It's like mu opiates related to pain, Kappa not, other stuff. And so there is a well delineated set of mechanisms here that when you have stress, dynorphin is released, which binds to kappa opiate receptors that are on ventral tegmental area neurons that project to the nucleus accumbens, an important reward center, and they inhibit the release of dopamine into the nucleus accumbens and basically decrease its activity level. So we thought, we're going to do a development effort on anhedonia, trying to test whether that hypothesis is correct, and we're going to test that mechanistic hypothesis before we go on to do anything with clinical endpoints. So we did a study where we first knew we had a drug. It had robust antagonist properties at this receptor, greater than 85% occupancy at the trough. And we carried out this proof of mechanism study using the monetary incentive delay task and tested whether blocking that receptor would lead to an enhancement of activity in the nucleus accumbens consistent with this model, and compared it to placebo. And there's also a personalization story here that's important. We're dealing with a subgroup of people. These are people who have anhedonia. We're not dealing with major depression. One problem there is major depression, I don't think, has a unique biology. And people have been trying to find it for many years and failing over and over. You know, Leanne showed us a biology being different in a bunch of different groups within the depression group. That's different biology that you would have to have different hypotheses related to those different groups. They have circuit dysfunction in different places. So that depression doesn't suit itself so well to this, but subgroups of depression do, and that was the strategy we take. So this is personalization at the subgroup level. So results, we did in fact establish proof of concept, proof of mechanism here, that we saw an increase in ventral striatal activation. I'm a little, unfortunately or fortunately, depending on how you look at it, we also showed a statistically significant effect on the clinical measure of anhedonia. The reason I say unfortunately is because every time I give the talk about this, people say, oh, it was a successful trial. You showed an effect on that clinical endpoint, the SHAPS scale. And the answer is no, it's a successful trial because we verified our proof of concept, our proof of mechanism hypothesis, and showed an effect on the brain that we expected would be there. This was an underpowered study for looking at a clinical endpoint. That was my assumption. You would need to do a bigger one. It turns out the effect size is big enough that in this particular measure with this particular drug, it happened to be positive, but that would not be necessary to argue we should move on to the next phase and do a clinical endpoint study. And just so you know what happened here, the drug we used was called aticaprant. It's a kappa opioid antagonist. And there's another one out there called navacaprant. Both of them went through phase 2 studies led by pharmaceutical companies, and both of them showed positive results, and they're now both in phase 2. It was interesting that phase 3, they've invested in the big trials now. So we'll see how it goes. But with the clinical endpoint studies, there were some slight differences between them. One of them had antidepressant effects, but because they're proceeding for indications in depression, because there's FDA precedent for that, there's a market for that. It's not so clear that anhedonia has a market and a simple pathway through FDA. So they're going for depression. And aticaprant only worked for depression in the subgroup of people who have anhedonia. And the other one, they didn't look at it subgroup-wise. They showed that there was an anhedonia therapeutic effect, and it was bigger than the major depression effect, but there was statistical significance on both. So we'll see what happens. Now, need to move on. I'm now going to shift from subgroup level personalization to personalization at the individual level. Huge leap. And in a circuit targeted framework, a mechanistic targeted framework, certainly circuit targeted. And this was related to deep brain stimulation. So in this deep brain stimulation, electrodes are planted directly into the brain. And basically, we did a study where we took all those deep brain stimulation sites that worked in some people that had been studied in the past and studied all of them in everybody. So we put electrodes in each of those places. And these electrodes each had 16 contacts. So we had a distal contact in those key places, plus 15 others that were in other parts of the brain. So we end up with about 100 contacts in the brain to explore. But just so you understand, all prior deep brain stimulation work has been done single site targeting, and they stimulate continuously for 24/7 for years. If you stimulate continuously for 24/7 for years, and you only see a therapeutic effect after 6 months to a year, you can't actually test different stimulation sites. We had a very different model. And our model was driven by the idea that we could achieve an immediate therapeutic effect, and also that it's possible to stimulate only when needed. And this was based on a DARPA subnet study that our group did, led by Eddie Chang. And so the idea is that we put in these electrodes, and we're actually going to test all of these sites and try to figure out what is the best place to stimulate this person, throwing everything else that we know out. Like, I don't care if what traits they have or whether they're part of whatever group. And then we identify also a personalized marker for depression severity. So we're recording intracranial EEG data from 100 sites and simultaneously asking people to rate how their depression severity is. And then we get an intracranial EEG biomarker of their depression severity. So then when we finish that process, that takes place over 10 frenetic days in the epilepsy monitoring unit. We explant people, and then we take the best stimulation site, and we take the best biomarker site, the brain electrical activity marker, and we implement it in a device that happened to be available, NeuroPace developed for epilepsy. And then this device stimulates the people at the site that was their best stim site, but only when the biomarker said their depression is elevated. So it's what's called a closed loop strategy. And this just shows you this, that I'm going to skip through this because of time. Just showing you, these are the places that we put electrodes. We put one on each side in the subgenual cingulate, the ventral capsule, ventrostriatal area, which is also known as the anterior limb of the internal capsule and is right next to the bed nucleus of the stria terminalis. And many of our people have had electrodes in the bed nucleus of the stria terminalis. Orbital, lateral and medial orbitofrontal cortex, hippocampus, and amygdala. So I think the key takeaway related to this talk, I wish I could talk about the results of this, we just don't have time. But the key takeaway for this talk is that it's very clear that there's tremendous variability among people, and there's huge need for personalization, because we saw both on the best stimulation site and the best biomarker are different in everybody. Of the people, we've had 5 people go through this so far. And of course, the numbers are tiny. I have no idea. Maybe there's 4 subgroups, there's 5 or 7 subgroups or whatever, there's 100 subgroups. We won't know until we study many, many more people. But the idea of that you can also, it's a kind of personalization to stimulate only when a person needs it. It turned out to be very helpful. We're stimulating people for on average 20 to 30 minutes a day, as opposed to continuously for years. Changes in the brain that could be bad are less likely. The safety profile is great. So there's a lot of benefits to it. I just want to show you, this is a very busy slide. And we've done 5 people. This is just the first 4 subjects. And I'm just showing you the therapeutic effect. So down means you've achieved a fair therapeutic effect. Placebo is in the first column there. And these are a bunch of different sites. And it just shows that we have statistical significance across actually a bunch of them. Like the idea that there's one site in the brain that is the site where for depression is absurd and clearly doesn't fit with the data. And and there's a best one, and the best one happens to differ between everybody. If you look at the one in the upper left corner, the first patient, you don't see much improvement. And the problem was that the first time this patient got stimulated in their bed nucleus stria terminalis, they had a remission. And, this is a person, these are severe treatment-resistant depression. This person's been non-functional for 15 years. And it had such a profound impact on her and hope that she said, oh my God, like I could get better. And she thought, it's not my fault. Like a minute ago, like I didn't need to do anything to get better. There was something wrong with my brain circuitry. It's not, certainly psychotherapy changes brain circuitry and could be helpful, but there is a lot of stigma in the field, and a lot of people believe that their behavior is responsible or something they're doing is responsible. So she was so good, we had to induce depression in her to be able to test sites with her consent, of course. But just so you can see that's what explains that patient. The others have all looked like this. I'm not going to go into the details there, but I just want to make it clear that we could find best sites, we could get immediate therapeutic effects in a bunch of places, and this is the list of the locations where people had their best stimulation site. So the first patient, it was in this bed nucleus stria terminalis, right next to what's part of the white matter, the ventral capsule, and but had good effects in other places, orbital frontal cortex, subgenual cingulate, but not as good. The second patient is listed as 3 here: right orbital frontal cortex and right subgenual cingulate, completely different. The third one, right subgenual cingulate and left nucleus accumbens. So there are 2 people who have the same site, right subgenual cingulate, which was interesting. And then the fourth person has the ventral capsule, ventral striatum, bed nucleus stria terminalis area there, but not on the right, on the left, unlike the first person. And then the fifth person is the closest to this. There's some overlap here, which suggests maybe there are some subgroups of people that the left bed nucleus stria terminalis ventral capsule area and the right, similarly, ventral capsule bed nucleus stria terminalis were best. So there's a little overlap among people. The distribution across sites is different. Best site has a lot of variation. And again, there's a range of places you can stimulate people. The other is the strongest biomarker was found in different sites in everybody: right amygdala, right orbital frontal cortex, right subgenual cingulate, left amygdala, and right ventral capsule, ventral striatum. No 2 people the same there. So it's clear personalization is needed. Now I want to jump to the question of, could this be done, like this kind of thing? Can you actually figure out targets in people and I'd stimulate their best targets in some real way? This is only relevant for the most severe, most crippled people. And the answer is there's some ways to move to non-invasive methods to do the same thing. Low intensity focused ultrasound is an option, and using focal drug delivery is an option, which with focused ultrasound, I'll tell you a little bit about here. Basically, you put a bunch of sound sources on the head, and because of the properties of sound, you can focus them down in one space deep into the brain where they all overlap. And in that place where they all overlap, there's a bunch of energy delivered and you have an impact on the brain. But where they don't overlap, there's too little to have any impact on the brain. So you can have a focal stimulation. And the stimulation is achieved with sound. You're actually vibrating the neurons. And there's complete uncertainty at this point about how that achieves effects. There's clear evidence of effects in multiple sites. Multiple people around the world have been documenting this. And are there vibration sensitive channels? Are there? Nobody knows. It's work in progress. And you use an MRI and you identify the place to stimulate and you do the computations and then you target places. And transcranial magnetic stimulation can target cortical structures, but a lot of our interest here is in subcortical structures, and LIFU, low intensity focused ultrasound, can do that. So I just want to show you the result of one patient. I may never see this again, but it gives you the idea. We did exploratory stimulus response mapping in this person, just like we do with the electrodes implanted in the brain in people with deep brain stimulation. And we found the best site in this person was the anterior nucleus of the thalamus. Now, we never saw that in anybody with our deep brain stimulation study, but we never studied that place. And part of the issue is when you do deep brain stimulation, you have to commit. You stick an electrode in the brain, you can't then, that's it. But here you can try as many sites as you want. We tried like 30 sites. And we expected that we would have relatively immediate therapeutic effects. You can see improvement in depression in panel C there, and the anterior nucleus of the thalamus improved people over time significantly more than placebo. Notice people get gradually better over the course of a few hours. They do with placebo because of attention and so on, but they did more with the anterior nucleus of the thalamus. And the bed nucleus of stria terminalis, which was so effective in some people with deep brain stimulation, was not any better than placebo here. But anterior nucleus of the thalamus effect was statistically significant. And then we showed that if you look at resting state MRI, this anterior nucleus of the thalamus was associated with a decrease in resting state connectivity in the default mode network versus sham. Now, this is one person. I may never see this again, maybe a false positive, it doesn't matter. The point is just it's an illustration of the kind of thing one could do non-invasively based on the deep brain stimulation work and allows personalization at the individual level. And then just a couple of points. You can deliver drug locally with low intensity ultrasound if you can encapsulate drug and inject it systemically, and then you can have the ultrasound opens the little capsule only in the little focus of the brain where you stimulate with ultrasound, and it's a way to do focal drug delivery. You can also, with bubbles, we oscillate them, open the blood-brain barrier locally, and get systemic delivery of drug locally to an area. Rag Aaron here at Stanford is the pioneer in these little micro bubble drug delivery things. And so exciting options, not much clinical data yet. So I'm going to wrap up here. And I'm going to argue we should develop our novel therapeutics in a rational scientific framework if we want to do better than we're doing with depression. And I think we need to do better to how to figure out how to personalize therapy so we don't just develop new treatments and not have any idea who to give them to. So my philosophy is if you know a target to stimulate, and you can do studies then, carry out a trial to see what happens when you engage it at the level of clinical outcomes. If you haven't established proof of your mechanism, do that first and then do it. But what do you do if you don't have targets? And that's where we are for many disorders. Well, you can do exploratory stimulus response mapping, perhaps with what we're doing with deep brain stimulation or ultrasound. But my recommendation is don't bother doing studies otherwise, because it's just a waste of money and it's killed our field in some ways, particularly with drug development. Last slide is fantasy of mine. The future that I hope we'll see is every person who comes to clinic to be seen will undergo some kind of assessment procedure, and we'll find out exactly where in the brain their circuitry is dysfunctional and that's associated with their symptoms. And then we'll target that dysfunction specifically in those people with some kinds of methodologies that are available or emerging. Whether we'll see this or not, time will tell. Thank you.
Okay, we'll have time for a couple of questions before lunch, and I'm sure we'll have lots of discussion in the panel. So let's see, one at the back. Yes.
Dr. Krystal,
yeah.
In looking at the individual foci that you stimulated and showed response to treatment, considering that the depressogenic areas in the brain, do you think that they're separate and independent, or do you think that they're connectomes of one another?
I think they're connected.
Yeah.
I think we're seeing broad circuit activity, and you can impinge it on at several points. This raises a really good point. Our best stimulation site may have to do with exactly where our electrode ended up, and may not be, the fact that that person is best treated, let's say, at the bed nucleus of stria terminalis. If we had gotten the electrode in the right place in orbital frontal cortex, it could have been just as good in that person or wherever the circuitry is. So my hope is that our field will move to a circuit-based approach and start thinking about these regions as interconnected and able to be impacted in multiple ways.
One other question, if you will. In the studies where you showed that anectin was useful in treating depression when anhedonia was present, did that imply that it's also useful in TRD when anhedonias are present?
These were not treatment-resistant patients.
Okay.
And I don't know the answer to that. The two FDA development processes that are going on, one by Pneumora and one by Janssen, are not in treatment-resistant depression. They're taking regular depression, which is super risky. You know, just the study design of a single agent therapy for depression does not work so well. Drugs fail over and over and over because the placebo response rate is so high. So augmentation strategies in treatment-resistant depressed patients succeed much more often because the placebo response rate is lower. Yeah.
Hi, I have two questions, but I can just do one if we're short on time, so let me know. The first question is, it's really cool and really promising that you have these rapid acting effects. I'm curious how long they last for.
So,
and does it need the continual stimulation to do that?
One thing to appreciate is that we are trying to do brief stimulation over and over and over. And so if you stimulate very briefly, you can get an immediate effect, and it might last 10 minutes, 20 minutes. If you do a train of stimuli, which we do when we have people in the epilepsy monitoring unit, let's say you stimulate them for a half hour, they'll stay better for 4 hours, 3 or 4 hours, something like that. And, you know, so, but our stimuli are happening briefly over the course of the day, intermittently. And so the strategy is actually suited for the idea that the effects are temporary. And lots and lots could be said about this, but what we're doing is a little bit complicated because if you think about it, we have a biomarker for depression severity, and we're waiting till that biomarker says depression is present, then we're stimulating and we're bringing stimulation, the depression severity down. And it, by the way, normalizing the biomarker also. It tells us, like, let's say if we're using beta activity in the amygdala, so you have a burst in beta activity in the amygdala, we stimulate and the beta activity gets suppressed. And if you do that, you would think people would go up and down and up and down and up and down. They'd get depressed, you stimulate and bring them down. That's no good. Turns out they don't get depressed at all. We stimulate at a level, we establish treatment at a level where they can feel it and they get better immediately. And then we stimulate them for treatment at a level below where they can feel it, because it would be just disruptive of their lives to be, well, I can feel the stimulation, and then, you know, it goes away. And then I feel stimulated. So they can't have any symptoms. We eliminate that. And then what happens is they just stay better all the time. They don't have ups and downs. And I think it's because I think of it more as targeting a circuit activity than the clinical state. Like initially it's correlated with clinical state, but then it actually gets decoupled from clinical state over time because of circuit rearrangement. This is a really whole other interesting story. We do evoked potential mapping where we stimulate and record from a bunch of places in the brain to study connectivity. And let's say the first patient, we're looking at amygdala is the biomarker beta activity. And every time that's elevated, we stimulate. The circuit rearrangement has happened to suppress beta activity in the amygdala. It's now so tiny that we've had to actually increase the sensitivity of the biomarker to be able to pick up her activity because of that. So the brain is reorganizing itself. It's a dynamic process. And I wouldn't say anymore it's a biomarker for depression. It was at one point, and now it's a biomarker for activity in a circuit that seems to be important for depression, for detecting the process related to depression, maybe before it gets expressed. I don't know. We'll see. Oh, yeah. Is that okay, Leanne?
It's okay. So my second question was, and you might have mentioned this and I missed it, but is there a way, it seemed like you had all these different places and you can stimulate them differently, and it's a different combo or a different place that really helps the patient. Is there a way to predict which location it will be by pre-scans or something?
You're not the first person who has thought of that. We've been working at that for a while. It's a great question. What we'd love to be able to do is to figure out what the best place to stimulate each person is by using like serial MRIs or EEG or something non-invasive, so that we can skip that epilepsy monitoring unit period and just put in one electrode in that site, and also do the same with the best biomarker site. So we haven't been able to do that at all, and we're trying. But so we're collecting MRI data and EEG data and a bunch of other things with the hope we can predict it and skip that whole epilepsy monitoring unit phase.
Hi, so I'm not a scientist. I work in fundraising for psychiatry, and I'm thinking about this.
I'd appreciate some funds, by the way. While you're,
It's terrific,
Yeah.
but here's what I was thinking, that so many of our donors to psychiatry or this area just like want things to happen now. You know, they want clinical outcomes. And I'm just wondering how you discuss the need for deep research into mechanisms and mechanism of action, and explaining how that's so important.
for the deep brain stimulation.
Well, for any work that we're doing in psychiatry, the mechanism of action,
How the mechanism of action is.
is so important, rather than just jumping straight to clinical outcomes when you're trying to. I'm just curious what your thoughts would be, because I'm sure you've interacted with a lot of.
My perspective on this is that mechanism of action is critical. You can have successes by chance, but knowing mechanism of action will speed up innovation and hopefully improve the capacity to help people better than we do with stuff that's just, it happened to happen. Like, our antidepressants are all the grandchildren of a tuberculosis drug, a monoamine oxidase inhibitor. It was given for tuberculosis, turned out to have antidepressant effects, and that led to the whole idea of serotonin and norepinephrine, many drugs that do that. And we've been repeating that story over and over and over and over and over. And then we accidentally found, I think, other things. Ketamine was somewhat accidental discovery, and that's the way we operate. Like, we're not driven by theory. If we had a theory that actually explained it, maybe 30 years ago we would have come up with ketamine, and we would have know exactly how to dose it, and we would know who to do it in, that kind of thing. So I think it could help you do better.
I think I know we have a lot more questions. I would suggest, if you're open to it, talking to Dr. Krystal during the break, and then we'll have extended discussion at 2 p.m. in the panel session. I'm just aware that